Hello everyone, I'm Dr. Sharan from the Department of Pediatrics AIIMS. Ever since being declared a pandemic in March 2020, COVID-19 has spread across the globe, affecting more than 213 countries and claiming over 7 lakh lives. Knowledge of its diagnostic tests are still evolving, and it is important that we have a clear understanding of the various tests available and their interpretation. Here is a brief outline of our presentation. We will be touching upon the WHO case definitions, the latest testing guidelines by the ICMR, and the different samples used, and also we shall be briefly looking into each of the various testing methods available. The novel SARS coronavirus 2 is a RNA virus, and it is around 200 nanometer in size. It binds to the ACE2 receptors through the spike glycoprotein, which is central to its pathogenesis. The neutralizing antibodies seen as early as the first week after symptom onset, they are directed primarily against the S, that is the spike protein, and the N nucleoprotein. Incubation period, that is the time between exposure and the onset of symptoms for COVID-19, ranges from 2 to 14 days and an average of 6 days. WHO has listed case definitions for the purpose of risk stratification of individual patients and to help us in the optimal utilization of the limited testing resources that we have. A suspect case is defined as any person with fever and respiratory symptoms like cough, breathlessness, sore throat, etc., and a history of travel or residence in an area where there is ongoing transmission of COVID-19 14 days prior to the onset of symptoms. For example, any person residing in or with a history of travel to a hotspot or a containment zone develops symptoms within 14 days of return, then he or she is a suspect case. Similarly, if a patient develops symptoms within 14 days of having contact with a probable or a confirmed case, then he too should be called a suspect case. Also, if there is no other alternate explanation for the patient's respiratory illness, then he too will be grouped under a suspect case. In a setting of a pandemic, individuals fitting into these criteria are highly likely to be infected with the virus and have to be prioritized for early testing and isolated in a timely manner to prevent further spread. A probable case is one where a suspect case could not undergo testing for some reason or the testing was inconclusive. Confirmed case is one with confirmation of infection through nucleic acid detection. For its testing guidelines, ICMR prioritizes testing of patients with influenza-like illness, abbreviated as ILI. It is defined as presence of fever, that is temperature of more than 38 degrees centigrade, and respiratory symptoms like cough, breathlessness, and sore throat. ICMR recommends testing individuals who develop this influenza-like illness within 14 days of return from overseas, or in migrants developing ILI within 7 days of return from their hometowns. Also, hospitalized patients, frontline workers, and healthcare workers developing influenza-like illness have to be tested. Asymptomatic individuals who have contact with a confirmed case should be tested between 5 to 10 days after their last point of contact. This is keeping in mind the maximum viral load being present during the initial phases of illness and the average incubation period, which is 5 to 7 days. Hence, testing the individual between 5 to 10 days of exposure is likely to have a better yield. Severe acute respiratory illness, that is SARI, is defined as patients with fever and respiratory symptoms that warrant hospitalization. These patients need to be tested regardless of their history of exposure. Upper respiratory samples like the nasopharyngeal and throat swabs are most widely used for the diagnosis of COVID-19. Sample collection is an aerosol generating procedure and poses a potential risk to the healthcare workers and warrants donning with appropriate PPE. Saliva is emerging as a substitute specimen for virus detection. Data is still emerging, but it is said to be 90 to 95% sensitive in comparison with nasopharyngeal swabs. Rationale behind using saliva as a suitable specimen is: 1. Salivary glands are rich in ACE2 receptors and could potentially harbor the virus during the acute symptomatic phase. Secondly, sample collection is safe and cost effective, and it does not require trained personnel donned in adequate PPE. Bronchoalveolar lavage is primarily used in intubated patients and is said to have a better yield than upper respiratory tract specimens. The serum is used for testing antibodies. It is useful to detect past infections and knowing the seroprevalence for epidemiological purposes. RT-PCR is the gold standard test for COVID-19. Let's briefly look into its steps. The virus is first deactivated from the sample by using lysis buffers, after which they are treated with a reverse transcriptase enzyme. So this reverse transcriptase enzyme generates a complementary DNA from the viral RNA. Next, we use primers and DNA polymerase like the Taq polymerase to identify specific viral nucleotides like the N gene, S gene, etc., and amplify them in logarithmic proportions. So the primer, which is synthesized in vitro, attaches to specific viral nucleotide sequences and activates them. The DNA polymerase further amplifies them. An activated Taq polymerase also triggers the TaqMan probe to emit light, and the amount of light is directly proportional to the amount of viral particles in the specimen. This light can be measured by the RT-PCR machine. Since it is a novel virus and has a very high rate of mutation, more than one primers are used for a single RT-PCR test. Pooled RT-PCR tests a maximum of 25 specimens in a single session of RT-PCR. In this, samples from 25 different individuals are tested as a single sample through the RT-PCR. A negative result labels all the samples as negative, and in case of a positive result, the individual samples are tested separately. Pooled RT-PCR can be applied in scenarios where there is a very low pre-test probability, that is while screening asymptomatic foreign returnees or migrants from green zones. This makes for better economical use of our limited testing resources. CBNet works on principles similar to that of RT-PCR, and it is already well established in the diagnosis of tuberculosis. It involves an automated process where the sample is processed after being fed into the machine, and specific viral nucleotides are extracted by the machine, and it is further amplified similar to the RT-PCR technique. It is further detected by qualitative assays. Cepheid Expert Express SARS coronavirus 2 is been validated by multicentric trials and is found to have comparable sensitivity and specificity as the RT-PCR. It detects the N and the E gene and has a turnover time of about 45 minutes. The CBNet, although more feasible than the RT-PCR, still requires a 24-hour air conditioning and an uninterrupted electrical power supply for its smooth functioning, which is not feasible in most of the peripheral health settings in India. It is used when results are required fast and patients are not symptomatic or mildly symptomatic and are going for urgent procedures like surgery or endoscopy. TrueNet is a mini version of the CBNet or the GeneXpert, and it has a turnover time of approximately 1 to 1.5 hours. Being battery operated and portable, it can test up to 4 samples per batch. These features make it ideal for testing in peripheral healthcare centers, and it is found to have similar sensitivity and specificity to CBNet. A negative TrueNet result does not require confirmation by a RT-PCR. Rapid antigen testing kits have bridged the gap for need of a point-of-care test that is reasonably sensitive and highly specific. It gives the result within 15 to 30 minutes of sample collection, and it has been validated by both the ICMR and AIIMS and is found to have a sensitivity of 60 to 80% and a very high specificity of more than 99%. Current recommendation is to test all suspect cases with a rapid antigen test, and if positive, the results are interpreted as true positives. Negative results have to be reconfirmed by a repeat RT-PCR. After sample collection, the swab is drenched into a buffer solution where the viral particles, if present, are extracted. The solution is then dripped into a specimen well, and the card is read within 15 to 30 minutes of sample dropping. The assay detects the S protein of the virus, and which if present, the specimen will give out a visible readout as shown here. Next we come to the serological tests, which are ELISA based tests detecting both IgM and IgG antibodies against the nucleocapsid or the spike protein of the coronavirus. These tests indirectly measure the host immune response and are particularly useful in children with mild or moderate illness who usually present late. IgG and IgM titers are found to appear at similar time points, that is after the first week of infection, and peak at around third week of infection. IgM titers have shown to decline subsequently, whereas IgG are said to last longer. Recent tests have shown that these antibody tests have a very high specificity of more than 99% and a sensitivity of 90% at the end of first week and 96% at the end of 2 weeks. Utility of serological tests is primarily to estimate the burden of the disease in the community and detecting past infection, especially in children who are usually asymptomatic and present late. A positive antibody test does not mean the person is immune to COVID-19. Currently, there is no evidence to suggest that seroconversion prevents further infection. Other non-specific lab parameters include lymphopenia, race, CRP, D-dimer, and ferritin, fibrinogen, and IL-6 levels. Additionally, multisystem inflammatory syndrome is characterized by elevated inflammatory markers along with raised creatine phosphokinase, troponin I, and dilated coronary arteries and reduced ejection fraction as seen in echo. Repeat testing prior to discharge is recommended only in severe cases, that is patients with a respiratory rate of more than 30 or saturation of less than 90% on room air, or patients who developed ARDS or shock. Immunocompromised patients have shown to shed viruses for a prolonged period of time, and testing them negative prior to discharge is also being practiced. Studies have shown that the most common CT finding in children is the presence of ground glass opacities, subpleural in location, mainly involving the periphery and the posterior lungs. Image A shows a distinct ground glass opacity involving the posterior aspect of the right lung, which is well localized. Image B shows consolidation in the inferior lobe of the left lung surrounded by ground glass opacities. Image C is that of a child with severe disease showing diffuse consolidations and ground glass opacities in both lungs. To sum up our presentation, RT-PCR in an appropriately collected nasopharyngeal swab is the gold standard for diagnosis. CBNAT and TrueNAT have been validated and do not need a confirmatory RT-PCR. Although not very sensitive, rapid antigen test is emerging as an ideal point of care for screening. A negative RT-PCR does not rule out COVID-19 infection, and as a single RT-PCR test has a sensitivity of around 80%, antibody tests have no role in diagnosis of active infection. Thank you.